Good afternoon. I'm Dr. Kay Wise Whitehead. Welcome to our plenary session. We're going to have an opportunity to talk about Black health and wellness, and we're going to do that until 6 p.m. today. We're going to open up with presentations from each of our panelists. We'll take some questions from the moderator, and then we'll take questions from the audience. We are so excited to have you join us in this discussion. Joining us today is Dr. Vanessa Northington Gamble. She has her MD and her PhD. She's a University Professor of Medical Humanities and Professor of American Studies at George Washington University. Dr. Gamble, how are you?
I am fine, thank you.
Thank you for joining us. Dr. Stephanie Evans is always with us, Professor and Director, Institute for Women's Gender and Sexuality Studies, Georgia State University. Hi, Dr. Evans.
Hey, Dr. Kay.
Glad to have you with us. I'm also joined by Dr. David Williams, who is the Norman Professor of Public Health and Chair of the Department of Social and Behavioral Science at Harvard University, the T.H. Chan School of Public Health. Dr. Williams, how are you, sir? You are muted, sir.
Good to be here. I'm doing well. Thank you.
Very excited to have you. And then finally, last but definitely not least, Dr. Thaddeus John Bell, medical doctor, founder and CEO of Closing the Gap in Healthcare Incorporated. Dr. Bell, how are you, sir? And you are also muted.
Thank you very much. Happy to be here.
I'm happy to have you. In the same order that I've introduced you, I'm going to ask you to do your presentations. We're going to hear from each of our panelists for about 15 to 20 minutes to talk about how they enter the conversation around Black health and wellness. We are thinking deeply about this coming after COVID-19, where we're in the midst of a global pandemic that particularly impacted the Black community. I think about the fact that I believe that we're actually in a syndemic, where we're dealing with multiple epidemics at the same time, from COVID-19 to poverty, to living in fast food swamps and fresh fruit deserts. We're going to talk about all of that and maternal health with our guests. Dr. Gamble, let's start with you.
Yeah, says first of all, we were not asked to do presentations. And so that what we were asked to do was we were asked to talk about our current research. So that's where we're going to start. So I think that none of us had thought about 15 to 20-minute presentations, that we really wanted to have this as a conversation. Okay. So that I'm just going to briefly talk about my research, the same way that my other panelists, we had discussed how we were going to do this. So I'm going to briefly, for about 5 minutes, talk about what my research is and how I got into this work. First of all, as you mentioned, I have an MD and a PhD. And my PhD is in the history and sociology of science. And so that and the reason I did the MD, PhD in the history and sociology of science is that I wanted to look at how social factors, we weren't talking about, social determinants of health or anything at that point in the 80s, actually the 70s. And so I wanted to look at how social factors impacted health, because as a physician, I saw that it wasn't just what's happening at the bedside, but where people lived, what they ate, and what kind of health care they had. So I did as I said, my PhD on the history and sociology of science, where I looked at the history of Black hospitals. Because one of the things that I think it's important to do is not just look at Black people as being oppressed in healthcare. That's an important part of the conversation, but I think it's also important to talk about what Black people did to take care of themselves when other people did not, or could care less about them. And so one way Black people did that was the establishment of Black controlled hospitals. The first being Providence Hospital in Chicago in 1891. And so I went from there to looking at not just hospitals, but other things that Black people had done for themselves. 30 years ago, I created the first course ever on the history of African Americans in medicine. And in that course, I looked at what happened in slavery. There's a lot of work now, great work, looking at the history of African Americans in medicine, and public health. But in the 90s, there was not. So a part of my work is not just to be doing research, but also to do teaching. So that teaching to not just people in the history of medicine, but also students and practitioners of medicine and public health. My current work, I'm doing a couple of things. One, I'm writing a biography of a Black woman physician by the name of Virginia Alexander, who lived from 1899 to 1949. And the reason I'm looking at Dr. Alexander, one, I'm very interested in the lives of my foremothers in medicine. But also, I think there is so little research on the history of Black women physicians. So I really want to do that. But the other thing is that, and I don't want to do this as looking at her as this, heroic Black woman against the odds, but to talk about her pain, talk about her struggles, to figure out how she got through. But the other thing that I'm interested in terms of Dr. Alexander is what have been some of the past efforts to eliminate racial and ethnic inequities in healthcare. The other thing that my research is looking at, I'm looking at the desegregation of medical institutions throughout the United States. I've looked at the desegregation of the University of Arkansas Medical School. People might ask, why do I want to look at the University of Arkansas Medical School? It was the first medical school in the Deep South that desegregated, and that was in 1948, before the desegregation of Central High School in Little Rock. And then finally, what I have been talking a great deal about recently is the 1918 influenza epidemic in African Americans. I wrote an article about 12 years ago about the topic. I have been talking more about the topic for the past 10 months than past 15 months than I have in all the years that I had published the article. And one of the things that I focus on in that article is that once again, that African Americans themselves had to take care of themselves at a time when other people did not. And so that when we talk about health and wellness in the African American community, we have to definitely talk about the activism of African Americans, including people such as Black club women, and to make sure that there is a comprehensive history of these particular efforts.
Thank you very much, Dr. Gamble. Dr. Evans?
Excellent. Thank you so much. As always, it is a pleasure to be here with my ASALH family. I entered this work, I'm the and wellness part. It's, the Black family and health and wellness. Through my new book that just came out this February, Black Women's Yoga History, Memoirs of Inner Peace. And so how did I get to study inner peace? I study Black women's intellectual history. I've always been fascinated by the stories Black women tell, just as Dr. Gamble was just saying. How do we take care of ourselves, or how do we teach and learn, or how do we manage what we need to manage? So my first book was Black Women in the Ivory Tower, 1850 to 1954, an intellectual history. And so over the years, looking at Black women's ideas, and specifically Black women's ideas as they're represented in life writing and memoir, I came to kind of this easy transition to ask questions about from what have Black women written about education to what have Black women written about mental health. And this is a really personal question for me, because in thinking about, mental health and public health in terms of personal stress and social stress and structural stress, all of these things around 2013, 2014, 2015 started to hit at the same time. The personal stress, I suffered, unfortunately, a miscarriage in 2013, and both of my parents died within 6 months of each other. And it was really a challenge just to hold on. At that time, I'd already been asking questions about self-care and histories of self-care and practices of self-care, because at that time I'd been chair for a decade. So, now everybody's like talking about what it means to be a department chair. That work level stress was just hitting an all-time high. So when I started to, revisit the library of Black women's life writing, and look at people like Anna Julia Cooper, for example, who I'd been studying for quite some time, as an intellectual, as an educator, as an administrator, I started asking questions like, how did Anna Julia Cooper live to be 105 and a half? What were some of the strategies that she employed? And so I started to revisit these questions of memoirs, and particularly elder memoirs, to help me through the personal struggles, to help me through what was going on professionally. And then in 2016, the political, the structural aspect, the explosion happened. And so I started to ask the questions about stress management and how self-care is represented in Black women's life writing, because all of these things had kind of started to come together. And so I looked at the APA. They have a national stress report, right? That after 2016, the 2017 report was, kind of an indicator that we collectively in the United States were beginning to hit all-time stress highs. And then I started to ask the question, well, how do we manage stress, right? And that report revealed that we listen to music, we exercise or walk, we pray, and we meditate or do yoga. And so I started to ask questions about, where can we find representatives of these historical stress management strategies in Black women's life writing? And if we're looking at nonagenarians and centenarians, what are some of these strategies and practices? We see it in Anna Julia Cooper in her meditation. She had a daily meditation practice where she would write in the morning. We see music, Marian Anderson, the opera singer. We see prayer, people like Debbie Roundtree, who was an activist, but also was very active in the church. We see the Delaney sisters, who were doing yoga, started in their 60s and then lived to be 109 and 104. And then Ida Keeling, who is now 106, who started running in her 60s. So these are the practices that I started to pull together. But my final point is, I'll stop here. I settled on yoga because I ran into a picture of Rosa Parks doing yoga. And it changed everything that I thought I knew about the historical wellness practices. And so just focusing on that history led me down a very interesting pathway that I'm still continuing on. I grew up, in DC, and my parents were in the Howard Theater, and we all were always on jazz, right? Jazz music, jazz dance. And so when I grew older, yoga became one of my practices that felt natural, that felt very connected to my practice, my historical practice of dance. But looking historically at narratives really gave me a whole new sense of what this history was.
Thank you, Dr. Evans. Dr. Williams, I'll come to you now.
Thank you. Now, I must give a caveat. I'm not a historian. I'm a sociologist, but I happen to, in addition to my appointment in public health, I'm also a faculty in African and African American studies at Harvard, and there's a colleague of Professor Evelyn Higginbotham, and she told me it would be good for me to talk about some of my research on the impact of police killings on the health of African Americans. And I told her, yeah, I could do that, but I would want to broaden it to talk more generally about my research on racial discrimination, and I'll talk about police killings as one aspect of that. So I'll just try to give you a brief overview. Probably I am best known in medical public health circles for my work on developing measures to capture the experience of discrimination. And I developed multiple measures, but there's one scale I developed called the Everyday Discrimination Scale that is now the most widely used measure to capture interpersonal discrimination globally. What it does, it doesn't capture all aspects of discrimination, but it captures the day-to-day indignities. It has questions like, in your day-to-day life, how often are you treated with less courtesy than others, treated with less respect than others? You receive poorer service than others at restaurants or stores. People act as if you are not smart. People act as if they're afraid of you. People act as if they're better than you are. So it's 9 items that just captures these little indignities. It's the kind of stuff that African-American psychiatrist at Harvard many years ago, Chester Pierce, back in the early 1970s, he coined the word microaggression, microaggressions. And he talked about the assaults to Black dignity and Black hope that are incessant and cumulative. And really, I see the work that I have done and others that have followed my lead documenting the dramatic, adverse, negative impact of these little indignities. Just to give you a sense of, I haven't done all this work, but just some of the findings that have been found with people using the Everyday Discrimination Scale. If you score high on the measure of everyday discrimination, you are more likely to have to develop breast cancer. You're more likely to develop diabetes. You're more likely to develop heart disease. It's linked to multiple markers of what we would call subclinical heart disease, like coronary artery calcification or intima media thickness, or heart rate variation, or AFib, just a broad range of outcomes. It's linked to poorer sleep quantity and quality. It's linked to higher obesity. It's linked to hypertension. It's linked to less engagement with the healthcare system. It's linked to more emotional distress, symptoms of depression and anxiety, but also linked to DSM-5 defined depression and anxiety disorders. So what I'm saying is the research is documenting that discrimination is having an adverse effect on the physical health and the mental health of the African American population, and I would say other populations who experience these measures of discrimination. There are now studies from the United States, from the United Kingdom, from South Africa, from Australia, from New Zealand that shows if you look in each of those societies at a disadvantaged racial ethnic population and a predominantly white population, in all of those societies, if you're a racial ethnic disadvantaged population, you have worse health. Researchers used to think that income and education explains that. It accounts for part of it, but even after you take income and education into account, race still matters for health for disadvantaged populations across these countries. But what the research is now documenting, when you add statistically a measure of discrimination, interpersonal discrimination to the model, you further explain the racial disparities in health. Another way to say that, we now have statistical evidence that one of the reasons why there are racial disparities in health for African Americans is that Black people are being treated badly in their day-to-day life, and that has pervasive negative consequences on their physical and mental health. My research and that of others is showing there are also a number of what I would call hidden ways in which discrimination affects health. So with one of a postdoctoral fellow working with me, Professor Brandisha Tynes, now at USC in California, we did the first study of online discrimination and the health of middle and high school students. And what we found in that study, among these students, that the experiences of discrimination in online contexts adversely affected symptoms of anxiety, symptoms of depression in those kids, independent of a measure of global adolescent stress and independent of discrimination offline. So that just in the online context, discrimination was having a negative effect on their health. Let me talk about my study that I was involved with some other colleagues on police violence. What we did, we used a database of police shootings that has every police shooting that occurred in the United States over a 3-year period. And then we used data from the CDC of the mental health of blacks and whites in every state in the United States. And we linked the two together. And we were able to show that every police shooting of an unarmed African American led to worse mental health, not for just that person's family and friends, but the entire black population in the state in which it occurred. So there is this negative impact, because I think I should say two things. One is the effect was specific. In the database of police shootings, we could look at police shootings of an armed person or of an unarmed person. Police shootings of an armed African American had no effect on the mental health of African Americans. It's only the police shootings of an unarmed person, and we think what was operative there is the perception, because the person was unarmed, this was unjust and this was unfair, and not only that, it could happen to me. It could happen to me, my brother, my sister, my mother, my father, my child. In fact, I haven't done this research, but there's some recent research showing that over 70% of black mothers are worried about what might happen to their children in the hands of the police. And another study found that when they looked at mothers in 20 cities, African American mothers in 20 cities in the United States, and they found that their children on average had been stopped by the police, had a first stop by age 15. They had had at least one stop by the police. And they found that the mothers whose children had been stopped by the police had worse mental health that led to poorer sleep. Their sleep was affected because of the anxiety and depressive symptoms they have. One other way in which all of this loss of life is adversely impacting the African American population that we don't think about is what a researcher, I haven't done this work, but has called community bereavement. We know that African Americans not only have higher rates of disease and higher rates of death, but we also have this at younger ages. So that if you are growing up in the African American community, you are experiencing the loss of life of others in your social network disproportionately. Let me tell you what national data shows. Black children compared to white children are 3 times as likely to lose a mother by age 10. Black adults compared to white adults are twice as likely to lose a child by age 30 and a spouse by age 60. And so this massive loss of life, social support, social ties are one of those powerful resources that help us cope with stress and deal with stress. And we find that's true even for the stress of discrimination. And one of the things, the loss of life because of health disparities is really leaving higher levels of bereavement within the African American community. I just want to conclude by pointing out in this research on discrimination and health, their studies have identified 3 powerful resources that seem to cushion some of the negative effects. First, social ties, the quality of social relationships. I'll tell you about a study done by a researcher from Georgia, Gene Brody. He studied African American teenagers age 16, 17, and 18 in rural Georgia. And he was able to show that those who scored high on discrimination at 16, 17, and 18, consistently high at those 3 times, by age 20, I didn't say age 40, by age 20, you could see biological dysregulation in those young people. They had higher levels of stress hormones like epinephrine, norepinephrine, and cortisol. They had higher levels of blood pressure, higher levels of weight, higher levels of inflammation. At age 20, if they were high on discrimination at 3 points as a teenager. The good news is that relationship between the stress of discrimination and this biological dysregulation was broken if they were embedded in close relationships with their friends, their family, their teachers. So the quality of social relationships really reduce the negative effects of the stress of discrimination on their health. A second resource that has been identified in the research on discrimination and stress on health more generally is the power of religious engagement. I didn't do this study, but here's a striking study. National Study of African Americans in the United States. Those who scored high on 3 aspects of religious involvement: religious attendance, church-based social support, they're getting support from the congregation as an extended family, and then seeking religious guidance in their everyday life. Each of these 3 factors reduce the negative effects of the stress of discrimination on their mental health. And the final example wasn't a study of African Americans, but it was a study of First Nations in Canada. So this is the indigenous population in Canada. At the time of the study, this group among teenagers had the highest levels of youth suicide in the world. And the researchers studying this looked at 196 First Nation communities, and to their surprise, they found that although as a group, these communities had the highest levels of youth suicide, half of the communities had not had a single youth suicide in the last 5 years. So they began to wonder what's different about those communities that don't have these suicides. And what they found is what I would call those communities that engage in protests, advocacy, and empowerment. They found those communities that were fighting with the federal government of Canada for titles to their land, for the right of self-governance, for control over resources. They wanted to manage their education, their healthcare, their police and fire services, and that they had a building where they celebrated their culture. Each of these factors predicted a lower rate of youth suicide, and if they had all of them, the communities didn't have youth suicide at all. So it illustrates the power, to me, of protest, advocacy, and empowerment, and celebrating our history, our culture, having a place and a space where culture is we keep in contact with our past and with our history, is also a protective resource. So that gives you just a quick overview of some of the research documenting the negative effects of discrimination in multiple ways on health, and the ways in which the evidence is there are resources that can reduce some of these adverse impacts.
Thank you so much, Dr. Williams. I'm fascinated. I have a lot of questions for you. I'll go now to Dr. Bell.
Well, first of all, I'd like to say how much I appreciate having the opportunity to talk to you today. All 3 of the presenters ahead of me actually have, their information has a lot to do with what I do. I am a clinician. In other words, I've been practicing medicine now for 46 years. I'm very blessed to have been in a position to be able to do that. Having practiced medicine for that long period of time has put me in a position to look back as well as look forward to some of the issues that we have overcome and to some of the issues that we still have to overcome. I'll start off by telling you that my journey, and I consider it a journey, my journey related to health disparities started in 1972 when I was not the first African-American, but in the first 10 African-Americans to be admitted to MUSC, the Medical University of South Carolina. And during the 4 years that I was there, it was a horrific experience, to say the least. The challenges were great, but I was particularly overwhelmed with the poor medical treatment that African Americans receive. And as I continued to try to become a student of why that was the case, and recognizing that all of the things that all of you have already mentioned certainly have played a role. As I went into my residency, which was still in South Carolina, and then I got the opportunity to come back to the medical university on an administrative level, and then eventually as director of diversity for the entire university. It began to put the health disparities and how African Americans were being treated into its proper perspective. I thought that perhaps the health disparities and what I was seeing was just in South Carolina. And it really wasn't until I attended a conference of the National Medical Association out in San Diego, California in 2005. And that's when the health disparity issue had come full circle. I think the book Unequal Treatment had come out, and doctors were beginning to be aware that the issues that we were seeing as it related to health disparities was not only in South Carolina, but throughout the entire country. Now, I recognized very early that being a clinician and really loving to having the love to practice medicine, I recognized that I could not deal with the multiplicity of things that caused the disparities. But the one thing that I could deal with, and I'll tell you, before I went to medical school, I was a school teacher. I taught general science, biology, and chemistry. And so one of the things that I learned how to do very, very well, and that is explain difficult subjects to people in a way in which they could understand. I recognized very early in my medical experience that one of the primary reasons that African Americans died earlier, had a very poor outcome, and et cetera, was because of a lack of health literacy. Lack of health literacy. And one of the things that drove that lack of health literacy was distrust in medicine, myths and untruths that have run among the African American population for decades that we continue to hold on to, and I felt was directly responsible for our outcome. But I also recognize that the longevity and the quality of life was not only poor among African Americans who perhaps did not have a good health education, but it was like that for African Americans who were professional people, teachers, our lawyers, people who, at least I thought, should have good health literacy, and they didn't. And so I decided that I would come up with a program called Closing the Gap in Healthcare, in which I would go on radio and television and try to address issues that poor African Americans had as it related to medicine. For an example, why do you have to take your medications for high blood pressure for the rest of your life? A lot of Black people thought that, well, you just take them for the time that the prescription is given, and when the prescription runs out, you don't have to take them anymore. That was a very pervasive thought in our community. A lot of Black folk did not understand. They thought that diabetes came as a result of eating too much ice cream and candy, et cetera, et cetera. All right. So I recognized in a private practice and teaching and working in health clinics, working at the medical university, working in my private practice, I recognized that the people who could afford to pay for the healthcare, their outcome was really no different than the people that I saw in the health clinics. The disparity as far as information was the same. And so as a result, I started closing the gap in healthcare. We started writing health tips that we put on radio and television. And so for the past 18 years, I have written probably 2,000 or 3,000 health tips that are on radio and television. One of the problems that we ran into as we were doing this is South Carolina was at the top of the list when it came to health disparities. And I wanted to find out, and I noticed that many of my white colleagues didn't like to talk about that. They didn't like to talk about the health. They pretended as though the health disparities did not even exist. All right. And so I wanted to find out, well, what was behind that? Why did folk not think, or why did many of my colleagues not think that they could be contributory to the high amputation rate that we were seeing in African Americans in South Carolina? Why did they not feel that maybe they were not communicating with the patients that they were seeing? So I started making Black folk aware of what these disparities were. I challenged, and sometimes I got criticized significantly by the community. I started challenging why folk don't go to the doctor. It wasn't all about lack of access. That certainly played a role, but I recognized that there was a significant number of Black folk who thought that if you felt good, you were good. So why go to the doctor? And so I challenged that in our community. And then finally, what I did is I went to my university bought into closing the gap in healthcare, and they gave me a $100,000 grant in which I asked one of the researchers at the medical university to study what we have been doing to see whether or not it actually made a difference in our community in the Tri-County area. And the bottom line is that after that study was done, it showed that the information that we were putting on radio and television and the places that I was going speaking at churches, I was speaking everywhere. I was speaking in barbershops, wherever you asked, I would come and speak. And the bottom line was that what we were doing was making a significant difference. That's what the study showed. And so when the pandemic came about, we essentially was already doing what has been done as it relates to the pandemic. But we already knew that there was a significant amount of distrust that the African-American community had with medicine. So to be perfectly honest with you, I'm really not that surprised of the vaccine hesitancy that we have been seeing. I am a little bit surprised, however, of the hesitancy and the resistance that we are seeing from young people. And so what we did, my organization did, we did a little study to try to find out, why is the resistance among young Black people so great? Why is the hesitancy so great? And one of the things that we found out very, very quickly is that where they get their information from, they don't get their information from newspapers. They don't watch CNN. They don't watch NBC, ABC, and all of the regular places that we think people would get information from so that they can make good decisions. And we also found out that a lot of them between 18 and 40 years old don't have a relationship with a doctor. So you're telling people to go to your trusted healthcare professionals, they don't have no relationship with a trusted healthcare professional. So whether they get their information from, they get the information from TikTok, right, Instagram, Facebook, all right? Places where people like me would not ordinarily go to give information. So what we have done is we have hired some younger people to put us on TikTok, put us on Facebook, put us on all these other places where African American, particularly young people, get their information. And so our program, Closing the Gap, has been very, very successful. There still is a lot of work to be done. I still am impressed with the lack of just general information. Case in point, I got a little talk that I did on vital signs, just to explain to people what vital signs are. And I was surprised that most of the people who come see me had no idea why we take people's blood pressure. No idea about temperature, didn't know what a pulse was. Why you got to check my weight every time I come in here? Okay, so it's just little things like that that we try to teach our patients. So I think that, and there are a lot of documents from the CDC and otherwise showing that only about 12% of the total population have good health literacy. And African Americans' health literacy is even lower than that. And so that's what we do with Closing the Gap in Healthcare. And I appreciate having the opportunity to kind of explain that to you. Thank you.
Thank you,
Dr. K, could I have a follow-up comment on David Williams's presentation?
Yes, I was actually getting ready to come back to you. So yes.
Oh, okay. So David, you and I have been doing this for more years that we want to let people know. And I remember talking with you many years ago, probably in the Detroit airport when I was still in Madison and you were at the University of Michigan. And about and I used it for teaching this semester. The story that you talk about around the graduates of Yale, and and you can say what go into what that is about, because I think a lot of people think that sometimes it's the power of education, but some of the research has shown that education can be muted when there is everyday racism. And because I think it ties into, even though you started out saying that you're not a historian, it ties in to what Dr. Evans was talking about. And that is to try to use history to look at these narratives, to look at the narratives of people when you talk about, their social ties, looking at, religion, advocacy. Because I think one of the things that I have found in some of my research is that, especially if you look at diaries and letters, people talk about how they felt, how they were treated. For example, Virginia Alexander had lupus. That's when they thought lupus was a white disease. Because one of the things too, we have to look at the evolution of terms, evolution of ideas, and diagnosis. And she was at the Mayo Clinic, and she went there because it was the Mayo Clinic, but she could not get find a place to stay. She could not find a place to eat. And she wrote about this. And she talked about, we are getting a rotten deal, north, south, east, or west. And she was a Quaker. She says, I can't, those of us who are tired of the ballot have to find, or friendly ways of doing things, have to find a way to handle this. And so here she was writing about how she felt. She also wrote about how when her niece could not get into a Quaker school in the 1930s, and she said, and she cried. And she cried because something could have been done. So here you have this educated Black woman who graduated from medical school in 1925 when there were only 65 Black women physicians in the entire country. And she writes about how she felt, what Elijah Anderson talks about as being in the white space, and what are some of the consequences of being in the white space. And so another part of my life, I write narratives about what it felt like to be the first Black woman faculty member at the University of Wisconsin Medical School, and I wrote an article called Subcutaneous Scars. And so what happens? There's the research that shows the stress at the chromosomal level of Black women in terms of shortening of the telomeres that show stress. I keep saying I'm going to get a T-shirt saying you're not shortening my telomeres today. But that so that I think there's a way, and I think it's important to tie historical narratives, history with your research, because I think one of the things we have to do is that we have to talk to different audiences. So certain audiences, the research on everyday discrimination that you talk about will not resonate as much as the story that you talk about of the graduates from Yale. So you can talk about what that story is about.
Yeah, no, it's a good point. So I think I begin my TED Med talk with the story of there was an article in the Yale magazine of the class of 1970 of Yale. And what was striking was that 41 years after graduation, the death rate of African Americans in the class of 1917 at Yale was 3 times greater than it was for the average class person, the non-Black person in the class. And so the question they were asking, what it is. And if you looked at the lives of those people who had died, in many of them in the early 60s, they had from any kind of professional analysis successful careers. They had been educated, had earned high positions, whether they were in business or in academia or elsewhere, but yet we saw this dramatic earlier death rate. And what I would say in the health literature today, researchers are using different terms. Some use the term premature aging, some use the term accelerated aging, others use the term biological weathering to capture what is happening to African Americans in this country. And think of weathering. I like to tell you to think of, imagine a drop of water falling from the rooftop of the building you're sitting in. And if that water drips today, it's no big deal. But if day in, day out, week in, week out, there is a steady drip, drip, drip of water, the concrete sidewalk becomes weathered. It becomes eroded as a result of the constant exposure to adversity. So what the science is telling us is that for African Americans, your age is not only capturing how long you have lived. If you are living in these hostile environments, dealing with all the stress of discrimination, plus all the other stressors that we face, your age is also capturing how long you've been exposed to bad environmental conditions and how physiologically compromised you have become by such exposure. And you give the example of telomere length, a study done of African American and white women in the greater Detroit area, they're all at midlife. Telomere length is a measure of biological aging at the level of every cell of your body. And what they found, although the Black and white women were the same chronological age, the African American women were 7.5 years older biologically. And one national study estimates, looking at 10 markers of biological functioning, that African Americans at midlife are 10 years older. The same age of whites, but literally, biologically, physiologically, they're 10 years older. So what it's saying is, all the adversity we encounter as a result of the color of our skin our body keeps a record, and it is profoundly weakening us in really powerful ways.
And it doesn't leave. And I'll give a historical
Exactly.
example. A historical example. There is, if you haven't, there's a marvelous book called Balm in Gilead, A Journey of a Healer. It's by Sarah Lawrence Lightfoot. And she's talking about her mother, Margaret Lawrence, who was one of the first Black child psychiatrists, who went to, and she lived until she was in, her hundreds. She went to Cornell Medical School. No, she went to Cornell undergraduate, applied to Cornell Medical School, did not get in. She did not get in. And the dean, she had lived in Ithaca. I don't know, some of you know how cold Ithaca can get. She was living in an attic in Ithaca and working as a maid. Did really well, got through Cornell, applied to the medical school, did not get in because the dean said to her, we accepted a Black man 25 years ago. It did not work out. He got tuberculosis. And so when she told her daughter this story, after having this really successful career, she was in tears. So that, so I think that, those of us who are historians, one of the things that we can do, and I think, that, a lot of work that Stephanie does is to show these stories, to show the impact. So it's not just one insult, but it's continuing and how it affects one's life.
And then Dr. Evans, I want to bring you back into the conversation just to talk about this and then talk about some of the ways that we can counteract all of this hostility that we're dealing with every day.
Absolutely. This is, I just love, I love y'all. I love these people. It's so important to, have spaces like this so that we get a real sense of the value of what Black studies does, right? That you have to see things from a sociological, a historical, a medical, a literary, all of these different types of knowledges that we have. Kind of when you bring them together, we get to see the real kind of 360. So I was attracted to memoir because as Maya Angelou said, memoirs are like letters to our daughters. And she actually wrote an essay, a book of essays called Letter to My Daughter, in which she said that we have, I have these experiences and you can learn from these experiences. I've only had one child and it's a son, but I have numerous daughters. And so I took that as an invitation to look at, and not just say intellectual history of those who were in education, but autobiography in particular, memoir in particular, as a purposeful revelation of all of these things that we have gone through. And so, I'm a first generation college student. I didn't start college until I was 25. And so I was one of those people who didn't watch the news, who didn't read the newspaper, and, got my information elsewhere. When I did first enter college and I did take a Black studies class and I did take a women's studies class and, took a class like Women and Their Bodies. And I was like, I'm a woman, I'm gonna get an A in this class, right? No. And then you look and like, wait a minute, there's a whole wealth of information that we don't know about. So how do we get our information? And that's why I took the time to compile a library. There wasn't, kind of this one-stop shop of where Black women's life narratives were. And so for, the past decade or two, I've been cultivating this and mining this library because it literally tells me how to, in the words of Stephanie Shaw, what to do and be, right? Like how to do and be, and how to perceive, like where do you get your information? How do you make your analysis based on what? And my approach has been a survey approach, because you listen to one or two Black people And you may get kind of a certain skewed idea of what might be good for you, right? But if you, and there's, in the world of TikTok and Twitter and things, there's no guarantee that if you get, you have 2 million followers and 5,000 likes, that it's actually accurate, right? That's no guarantee either. But what you can get from a survey of a collective of narratives is perspective, right? And perspective by people who were particularly writing about their feelings, about their experiences in a way that makes you feel that you're not crazy, and in a way that's really instructive. For example, Harriet Jacobs wrote her autobiography in 1861. North Carolina was enslaved, wrote about escaping enslavement into her grandmother's attic for 7 years. And when I started surveying all of these narratives for the keywords of meditation and yoga, I was shocked that Harriet Jacobs, while enslaved, was writing about meditation. She was writing about being in a meditative state that was so deeply entrenched in her spirituality, right? She was writing about the 6-mile walk to and from to visit her children, right? And she was saying, I was meditating on freedom. So we have this idea of meditation that it's this way out thing, grounded in Asian philosophy, and that's not something, just sitting in a room thinking deeply and breathing about stuff that doesn't actually help. Here we have a narrative of someone who was writing about her purposefulness of a conscious understanding of what it means to want to be free and to be mindful and thoughtful about that. When you have, again, Rosa Parks as an example of someone who was active her whole life, right? That even after 1955 and she moved up to Detroit, she continued her activism. But because of all of these, all of the things that were pointed out, like this, the stress wreaks havoc on our bodies. And part of the reason why, again, this is personal is because as a survivor of sexual violence when I was younger, I developed an ulcer. I had a complete blowout and attack. And Robert Sapolsky is one I will add to that reading list of why zebras don't get ulcers, when he talks about all of the factors that are genetic, that are historical, that are environmental, all of the factors that go into creating a body that cannot process stress and that has these, certain reactions. And looking at these narratives of history, you realize that Rosa Parks had a lot of health issues, right? Not just when she was younger, but the stress from death threats when you are trying to change a social system had an impact on her body. So she began doing yoga and was not only doing yoga, but teaching yoga. There's a picture of her in 1974, a month after she turned 60, in some very advanced yoga poses, not just the bend over, touch your toes yoga poses, but, the bow pose where you've got your feet back behind your back, behind your head. And she's doing some extraordinary poses and teaching it. Here, a deaconess in the AME church, right, is teaching yoga. Well, she did that out of necessity. And you start to then listen to how she writes about her diet and, making these changes. And so we stopped seeing yoga or vegetarianism as something that, other people do. Specifically, the stereotype is only skinny white women do yoga, when in fact we have an African tradition as well as the Indian tradition. And so part of what reaching, kind of surveying these narratives to find out what is normal, what is healthy, what we should rightly fear in terms of structural racism, what we need to be aware of in terms of some community dangers that, that particularly around sexual violence, that we, aren't so public as police brutality, but still wreak havoc, as Tarana Burke's book I just finished, Unbound, kind of really reveals the havoc that that type of experience and violence wreaks. That when we have a kind of survey of understanding historically and a personal one, we at least me, can see a way out.
Thank you, Dr. Evans. Dr. Bell, I want to bring you back into the conversation because you were talking about trying to raise health literacy and taking the information into the spaces where young people are spending their time, onto TikTok, onto Twitter. But I'm thinking about raising the health literacy of the other generation. I'm thinking about my father's generation, the plus 65. He is not looking to TikTok, if he even knows what it is, for news and for direction. So how do we reach that group? And by the way, he's back in South Carolina where he was born and bred. And so in trying to get the information to him, to counteract the things he was taught as a child around health literacy, how do we become intentional? How do we reach all generations? And you're muted, sir.
That I was going to do this right. One of the things that we have to appreciate is that your father, who probably is in my generation, I'm 77, there was no health literacy because there was nobody around to teach it. And even if it was taught, it wasn't taught in a way in which he probably could understand it. One of the issues that I have noticed in my practice, and I'm approaching, as I said, 50 years of practicing clinical medicine, is that let's just go to the point of yoga and fitness. Well, to people in my generation, being fit was like work. Okay. And so even right now, when I talk to patients about lifestyle and I say, look, it's important. It is as important to protect you from having a heart attack by exercising as it is for taking your medication. You really have to take the time and break that down to people, because that never has been taught to us before. Okay, so it's just the common things. For an example, I spent a lot of time in the barbershop. I find out what's going on in the Black community by going to the barbershop. So the other day, I was in the barbershop and they were talking about prostate cancer. Well, I'm a prostate cancer survivor, all right? And so I just sit there and just kind of listen to the kinds of things that Black men said about prostate cancer and listen to all of the myths and the untruths that many of them, young as well as older Black men, had about prostate cancer. And about 99.9% of it was not true. And one of the big things was that, well, I don't want to, I'm not going to get that rectal exam. I'm just not going to do it. And all of the myths and the crazy things that they thought about as it related to that. Now, most of the time when I walk into a barbershop, it changes the conversation because people recognize me, they know me, they'll start asking me questions. And so we'll have to deal with issues as it relates to healthcare. The other day I was in there and somebody said, well, a guy was telling the guys in the barbershop that he stopped taking his blood pressure medicine because his blood pressure medicine was causing his kidney failure. Well, that's crazy. That's the worst thing from the truth. But that's what he had been told by other people who was giving him false information as it relates to health literacy. So one of the things that I'm finding out is that when you can give people good information, they are likely to make good decisions. One of the things that I have noticed, and you should have noticed as well, every week we have somebody in the African-American community who is popular, 55 years of age, dying of something.
Yes.
All right. And so when you look back and you start trying to figure out why all these young Black men who have means,
Right,
and why are they dying from prostate cancer? Why are they dying from colon cancer? Why are they dying from a stroke or a heart attack? It's all because of the lack of information. because they did not understand what the information was. Now, one of the reasons that we have a lack of information that we really do need to talk about, we have a lack of information because we don't have enough African-American healthcare providers.
Right.
We don't have enough Black doctors. We don't have enough Black nurses. We don't have enough Black dentists. It's just not doctors who are going to make the health disparities go away. It's going to take everybody in the healthcare arena. I have a very good friend who recently retired as the administrator of a hospital. Well, how many Black kids recognize that if you're the administrator of the hospital, you call the shots? They think doctors call the shots. Doctors don't call the shots. The hospital administrator calls the shots. So when you go to school, you need to look at perhaps considering being a hospital administrator. Or what about being a nurse? So I think that we just have to give our folk more information so that they can live longer. Well, I remember a couple of years ago, one of my very good friends called me and he made me aware that at least 10 African-American women who were deans at major colleges had end-stage breast cancer. It was discovered late. Now, why did that happen? Why did that happen? And I submit that it happened because I see this kind of thing in my practice all the time because nobody told them. Nobody, they had this thing about getting a mammogram. So I think that if we are really going to make an impact on the Black health of our people, we're going to have to do a better job at educating them about the common things. And one of the things that I have noticed is that white folk don't explain things to us in a way in which we can understand it. And I also get the impression that they do it so fast. Sometimes they don't want us to understand. At least that's the impression that I get. Whenever I send a patient to see another doctor to get a consult, I always bring the patient back because I know that they are not going to understand what the consult said. They're not going to understand because the doctor who saw them got to get them in and out in 5 or 10 minutes, going to use words in which they are not going to understand. And the information is not going to be culturally sensitive. And sometimes our people get the impression, but they don't want them there in the first place. Okay, so I think that that kind of information is very, very important. And one final thing, we have to appreciate and we have to teach our people that knowing your family history is very important. I mean, we know that prostate cancer is a disease that runs in first-generation Black men. So you got to know, or you should be asking your father or your uncle, Dad, okay, you had some kind of cancer. Can you tell me more about it so that I can tell my doctor so he can be on the lookout for what you just had? I had a patient come in a couple of years ago. I made the diagnosis of prostate cancer. He had 6 sons. And so after I made the diagnosis and talking to him and finding out about his family, I said, well, by the way, are you going to tell your sons that you got diagnosed with prostate cancer? He wanted to know from me, well, why should I tell them that? And I'm saying, come on, man. You just got diagnosed. We diagnosed you in time. You're not going to let your sons know that they need to be screened starting at age 40 for prostate cancer. And if their doctor has not told them that, you need to tell them so they can tell the doctor, look, this runs in my family and I need to be checked out for this. So it's just those kinds of things that we do in closing the gap and that I think can make a significant impact on our population. I really get really upset when I'm seeing so many Black men, 55, 40, actors, people of means dying. And when you find out, well, what did they die from? I mean, it's just common things that I'm sure if somebody had told them, look, you need to do X, Y, and Z, perhaps they would have made a different decision.
Thank you, Dr. Bell. We want to ask you to start putting your questions into the chat box. We'll start answering them in just short order. Before we open up the questions, I want to just do one more round of questions. I want to come to you, Dr. Williams. I was thinking a lot about what you said about the everyday discrimination charge and about community bereavement. And I'm wondering, given the fact that right now the African-American community has been dealing with, in the last 18 months, not just COVID-19, which has been detrimental with the Black community, but also the murder of George Floyd, the unending images of the death of Black people that we've been dealing with for 5 to 6 years, but in the last 18 months, it's been an onslaught. Can you talk about how the Black community is doing? Because George Floyd and that murder was beyond just community bereavement. It was kind of a global bereavement that happened with Black people from South Carolina to Florida. We were all dealing with it.
Yeah, this is really a powerful question because all of these things are cumulative. So you're right. There is the pandemic. And remember, we have had the loss of loved ones at a disproportionate rate. African Americans have died from COVID-19 at a rate twice as high as that of whites. So we are losing, and that means we are losing family members, we are losing contributors to household income, we are losing key sources of support. And then you talk about so there's the pandemic of COVID-19 that's disproportionately hurting us. It's also causing a lot of mental distress in terms of, even when you lose a loved one, you can't mourn the way you normally could. Families don't get together and share that pain and grief and support each other because of COVID-19 precautions. So you have that, and on top of that, there's evidence of the negative financial impact that COVID-19 has had, particularly on populations of color, but it's on poor people in general in the US who, because of COVID-19, have run into financial difficulties. And you superimpose on that the pandemic of racism, as George Floyd's death brought it to life in such a vivid way for so many of us. So yes, there's no question, and research is documenting that the pandemic is having a huge mental toll on us. Another piece of it, there's so many aspects of it. The medical profession is talking about long COVID, and that is, okay, you got COVID, you got hospitalized, you didn't die, you made it out, but you're not okay. There are long-term negative effects on the respiratory system, on the cardiovascular system, that many people who have survived, they are alive, but they can't go back to work. They are not able to function at the level at which they function. So to be honest with you, there are so many ways in which this is such a powerful, stressful moment, and you talk about, we are in this era of rising, a rising, I don't know what to call it, right-wing movement in this country that seeks to undermine our dignity on a routine basis. So yes, we are under so many kinds of stress, and so I think the things that Dr. Evans was talking about have always been important, but never more important than now. And we need to find ways. I like to say to people that while we need to physically distance from each other because of COVID, we really don't need to emotionally distance because of COVID. We need to reach out and be in touch and support each other, and so on, because yes, there is a lot. We are being bombarded, and the cumulative negative effects. What the research is finding is that it's the chronic and ongoing stress that has the biggest toll. It's a stress that doesn't go away. Our bodies are remarkable at adapting to stress. We deal with the acute stuff, and then we recover, and we're doing well. But when there is no recovery, when it's ongoing, it doesn't end. And so I think we need to heed what Dr. Evans is talking about, of the ways in which, and Dr. Bell as well, I mean, the ways in which we can take care of ourselves and take care of our family and take care of each other. There's never been, I would say, a greater need for us to be there for one another with everything that we're facing in this world at this point in time.
Thank you, Dr. Williams. There are questions in the chat. I'm just going to read them out. And
Can I, before, there's something very important that I think we need to discuss.
Sure.
And that is that we have to be very careful, I think, to say it's one thing over the other in terms of some of these inequities in healthcare. That it's a very complex field. And you know, even to have to fight to be talking about health disparities, I think there's almost like this assumption now that we've always been able to talk about. No, we had to fight to prove. David was on the unequal treatment, the Institute of Medicine report in 2003, where it was documented that it wasn't lack of insurance while there were these inequities in healthcare. And so, you know, and to be able, you know, in 1963, it was thought that Black people's health was due because they could not get into hospitals. And, you know, Dr. Higginbotham mentioned the Simpkins versus Moses Cone case. And that was just for hospitals that got Hill-Burton. So that there has been an evolution in concepts, an evolution in factors that, you know, it is almost, we take it for granted that we're talking about racism in medicine. I remember in the 80s being at the CDC trying to look at when Diane Raleigh wanted to talk about racism and Black women's health, that we had to come up with some code words in terms of what we were doing. And the other thing too, that when we talk about health these days, we cannot just talk about health professionals. We have to talk about criminal justice. We have to talk about income inequality. We have to talk about environmental injustices. So that when we think about these inequities, I mean, the fact that there was a report in the 80s, it was in the 90s, where the term health disparities, there was a report where the term health disparities was taken out. We could talk about differences, so that, you know, that these are political terms that have evolved. And so I think that it's, you know, very important for people to understand that these issues are not just the purview of the healthcare system. I think that was, you know, that when we...
I just want to build on that point Dr. Vanessa Norton Gamble just made, because it's so important for us to keep that in mind. And so I remember in 2002, I was one of 3 scholars outside of the National Institutes of Health. That's a huge government bureaucracy that does research on health. And we were working with some subversives within. They wanted to get NIH to fund research on racism. And we called ourselves the Racism Working Group. And 3 of us from academia would have a monthly phone call with these people, African Americans within NIH from multiple institutes. And we were working on this meeting because they're trying to do it politically right, try to have a conference where you lay out the research agenda and then say there's a gap here and get NIH to fund it. When time came to hold the meeting, we called ourselves the Racism Working Group. They said, well, what will we call the meeting? We said the racism and health. Oh, they said, well, no, you can't use the word racism. We said, why not? We said, our director's not going to fund it. So remember, these are the subversives inside trying to make this be successful. They said, you can't use, we said, okay, let's call it the racial discrimination health. You can't use the term discrimination. We said, what? Why can't we? Well, because discrimination implies intent. And that's how they'll view it. So we can't use, so we ended up calling it racial ethnic bias and health. And they said bias, yes, good word, bias. It doesn't imply intent. Nobody is being blamed. And that's 2002. So, you know, and that was, so today when I see NIH saying we are doing things on structural racism, I'm about to have a heart attack. you know.
Can I also make a comment? I think Vanessa is absolutely correct. But one of the things I don't think we talk about enough, we don't have enough. Folk have to remember that the people who delivered the care are important. We don't have enough of the right people.
No, that's true.
Delivering the care.
Yep.
When I was associate dean in the College of Medicine, I remember I went to the AAMC right when the year changed, when the century changed, and they had a program called 3000
by 2000.
Yeah, and the objective was that we were going to have 3,000 new African American healthcare providers into the pipeline by the end of that, by the end of 2000. Not only did we not come close to that, we've gone in the opposite direction. So it is very, very important that we encourage our young people to consider going into the healthcare because, and we haven't even touched on mental health yet,
Right.
which is very, very important. But one of the reasons that we are dealing with so many mental health issues is because we don't have enough mental health care providers to be able to ascertain what the issues are and to look at the issues differently as it relates to culturally sensitive as it relates to us. So the bottom line is that we're going to have to increase the number of African Americans into the healthcare profession, which in itself is a major issue because when you start looking at the pipeline, by the time that our young kids get to the 8th and the 9th grade, they're dropping out of health, of math and science, sometimes being discouraged to go into math and science. And so as a result, if you don't have kids going into math and science and English, how you gonna be a healthcare provider if you don't pursue those things? So anyway, that's my 2 cents.
Well, Dr. Evans, let me bring you back in. Nichelle Smith had a question for you. She's very interested in your work, and she wonders how you talk to women about the notions that they may have meditative practices being against God. She put that in the chat.
Okay, very good. I'll first kind of weigh in on the importance of understanding the long history, not only of individual self-care, but the long history as everyone mentioned, building on Dr. Gamble's understanding of the struggle just to get here, right? And I think as important as it is to look at the wellness practices individually, I really kind of had a breakthrough understanding when I read Kamara Jones's kind of social determinants of health. And she was the first Black woman president of APHA to make racism in 2015, to make racism a public health issue. The American Association of Public Health, she said racism, and so she was building on all of the activism from the 60s, 70s, 80s, and beyond. And so I think it's important to look at the history of individual practices, but understand what public health is in all of its complexity, and that it is related to these social structures, that it's not something that you can just will away or something that you can meditate away or right? You have to meditate and do yoga and do all of these things and watch your diet and all this so that you have the mindset to fight and struggle to change the systems that are disproportionately impacting us, right? And so I agree with everything that's been said, and that's part of how I moved, kind of to relate the individual narratives to mental health history, but also to understanding the development of public health, in particular, also someone like Billy Avery, who was so consequential in moving from like our storytelling, right? Consciousness raising, the feminist practice of we tell our stories, then we start to see patterns, and then we can organize and communicate against these things, right? And so, you know, her activism in the 1970s and organizing resulted in, here in Atlanta, the Center for Black Women's Wellness, which is a fully functional clinic, right? That does community, community information about mammograms and all these different kind of services. And then Black Women's Health Imperative, right? Those are the two specific organizations that you've got an agency seeking to advocate policy changes. And so it's really everything from top to bottom, but starting with the individual practices, because as Sonia Sanchez says, you know, peace is a human right. So to answer the question about, you know, the idea that meditation is going against God, I think viewing the long history of people like Rosa Parks, who was an AME deaconess, right? Who was in the church teaching yoga, which she also mentions that she learned from her mother, that her mother was her first teacher. You know, and in Alabama, her mother, in the middle of the day, they would go outside and do calisthenics and exercises and stretches, which is why when she was in her 50s and 60s and 70s, and she lived to be 92, yoga was not foreign to her. Her mother, it was a community practice that they were taught. And so when you look at the people who, like Harriet Tubman, who, you know, who are marrying spirituality and meditation, or Ursula de Jesus, right, an Afro-Peruvian mystic in the 17th century who was in a convent, right, a Catholic convent. She was barred from being a nun because she was born enslaved, but she talks about meditating on the meaning of the crucifixion, meditating on the meaning of God, right? So if you look at meditation and even yoga practices from North Africa, you know, Egyptian practices, from South Africa, the Zulu dances, from East and West Africa, Makeda in Ethiopia, going up to visit Solomon, you know, doing Makeda and her people bowed to greet the rising and setting sun. That's a sun salutation. You know, all of these histories are very Black and very God-centered, regardless of what spiritual path you follow. And I think that all of this is really useful because it is so imperative to not fall into despair, because we have all of these problems and we have to, you know, it's our turn. We have to work. We've been working. There's work to do. But how do you not fall into despair? And that's what I think this work can help do.
Dr. Campbell, I'd like to have you chime in on that as well. This idea of not falling into despair. I've had quite a few people reach out and sending out tweets saying we often talk about just how difficult it is being Black in this country, whether we're dealing with the everyday discrimination chart or the community bereavement. What about survival? Like, how do we not fall into despair? That question that Dr. Evans put out. Dr. Gamble, I'll come to you.
You know, I think that, you know, David Williams talked about some of this when he was talking about things such as social ties, you know, the power of religion or even spirituality for some people, you know, the whole thing of not keeping things in, advocating. So I think that these, you know, these are some of the things. And I also think that we have to also think about not just surviving, but also thriving. That how do we find joy in our lives? It was, you know, there's some people that think it's, you know, like an oxymoron to be talking about Black joy. That, you know, so I think that these are some of the things. And then the other thing is, I think for me, you know, that history helps. You know, to see that there have been people who have thrived, who have done things. I mean, I talk to, you know, Black kids about medicine, and, you know, when they hear, you know, that the first Black woman doctor was in 1864, their eyes light up. I tell them it's around the time that, so we have a history of being here, of doing things. And so that, yes, I mean, one of the things that I think that Dr. Evans's work shows is people do fall into despair. I mean, and I think that for so many years, we as Black people did not want to talk about that. I wrote an essay in the book, The Black Women's Health Book. And, it's called A Dream Not Deferred on Becoming a Black Woman Physician. And I was asked to write this essay. And Evelyn C. White, who was the editor, thank you, you're holding up the, asked me to write whatever I wanted to. And he's like, I'm an academic. I'm used to telling you what you want and when you want it. And I thought I was writing about being a Black woman becoming a physician, but I ended up talking about my mother's death. And I ended up talking about my grandmother's death. I ended up talking about a major depression that I had. And I had people come up to me and said, why did you put your business out in the street? And I said, it was important for people to see someone such as me. You think, well, she doesn't suffer. Yes, I have suffered. I've sought help. I have also, found what David Williams talked about, social ties, spirituality. Anybody who knows me knows that protest and advocacy is a part of my DNA. So that I think that it's important that we also say, yes, we suffer. Yes, we need help. And yes, we will keep on keeping on.
I want to add something important. I have a piece of good news and bad news. The good news is there's a paradox in the health of African Americans. We do worse than whites on virtually every measure of physical health. When you look at mental health, the opposite is true. Most researchers believe there's a lot of evidence that stress leads to depression. African Americans have lower rates of depression than whites. And when this was with the highest quality scientific evidence, this is a pattern. So how come the stress leads to hypertension for us, but it doesn't lead to depression? And it reflects there are some resilient strategies that we have used for centuries that have kept us going. Yes, the road has been stony, but we've kept walking. And I think there are lots of ways in which we've done well. But I want to share with you the bad news. It's of the studies I have read in the last 5 years, this is the most disturbing to me, and I can't get it out of my mind. And I think we should all be aware of it. There was a study done that looked between 1990 and about 2012 and looked at the rates of suicide among elementary school children in the United States. It's not a sample. It looks at death certificate data for the whole country over this period of time. And what it found is that suicide rates among elementary school children stayed stable over time. However, they declined markedly for white children in elementary school. They remained stable for Asians and Latinos. Suicide rates among elementary school children doubled for African Americans. Recent reports show that pattern still continues up to 2016, 2017. And for me, it raises the question, with this world in which we live, and the young kids are so connected to social media and what they see on social media and everything, what does it mean to be growing up Black in this country? In elementary school, we are seeing African Americans, kids are having rates of suicide twice as high as that of whites, where historically, for 100 years, African Americans have had lower rates of suicide. And I think for all of us who have young nieces, nephews, whatever, in our lives, we really need to think of the challenges that these, our young Black this is age 5 through 11 age group, are facing, that is leading to this remarkable change in a pattern, that this increasing suicide among elementary elementary school kids is something we should all be concerned about, and as a community come together and support our young ones.
Dr. Whitehead, I like to also make a comment. One of the other things that I think that we need to try to do a better job at when it comes to healthcare, and that's talking about end of life care, which is a major issue. Not talking about end of life care creates a lot of anxiety and a lot of unnecessary debt and et cetera. I know very well about end of life care because I've lost two children. I lost a son at age 21, and about 3 years ago, I lost a daughter at 33. My daughter at age 33 was diagnosed with a rare form of cancer. And so in that journey, when she got that diagnosis, she started preparing me as well as the rest of our family for her eventual demise. There were just so many things that I learned from her as she took that journey. She developed a bucket list. She said, you know, Dad, I want to have a bucket list, and these are the things that I want to do. I got 10 things that I want to do before I pass away. And so we were able to do that bucket list. But after she passed away, one of the things that I decided to do was to do some investigation to find out how many patients actually get the truth or want to get the truth about their demise if they have a terminal illness, and how many doctors are willing to talk about it, and how many pastors are really willing to come and talk to a patient when they are looking at end of life care, and how much does it cost the family when there's nothing else that can be done for the patient, and the family wants to keep the patient in the hospital, racking up a lot of medical care when there's nothing else that can be done. And so I think that we don't talk about end of life care. End of life care, that discussion is as much a part of medicine as me treating your diabetes and keeping you from having a heart attack or stroke. And I don't think that we talk about that enough with our patients. So I just wanted to point that out.
Thank you so much, Dr. Bell. There are a lot of comments, folks, in the chat that I encourage you to go and take a look at. People are sharing their email addresses, they're sharing their areas of research. So do look to that as a resource. We are about 10 minutes or so away from ending our session. It does cut off exactly at 6 p.m. and it's at 5:46 now. I just wanted to go back around and give each one of our panelists an opportunity to say some closing remarks. If you would not want to say closing remarks, please inform me. There are questions that are coming into the chat, and I'm more than happy to throw a question to you. I'll start with Dr. Evans.
I'll say, the theme of the conference is the Black family. And I'm so grateful to ASALH for being a mainstay. And I know that you, Dr. Kayer, with the National Women's Studies Association and WSA, like these communities are lifelines. This is when I got together and started down this path to write about Black women's mental health in 2013, and came out with a book co-edited with the other Dr. Bell, Kanika Bell, who is a mental health professional and a psychology professor, and Nisinga Burton, who's a media scholar. The collaborative process of learning, right? We have to embrace the idea of Black joy. Black joy matters. These sister scholars helped me really expand on my commitment to lifelong learning, where there's not, you get this degree or you do this practice and then you're done. we all have something to teach and to learn, and it's the communal process. This is what conferences are supposed to do, conventions are supposed to do, is to bring together thinkers to strategize so that we can be more effective and re-energized in our daily work, particularly going back into the healthcare system or politics or academe, which is known for snuffing out the souls of Black women in particular, right? And causing so much stress institutionally that we cannot function. But gathering with ASALH, gathering with my sister scholars has really meant the world. And I really appreciate being on this panel.
Thank you, Dr. Evans, a professor and director for the Institute for Women's Gender and Sexuality Studies at Georgia State University. Dr. Gamble?
Yes, I too am glad for this panel. I got to see some people I haven't seen for many years. And but I want to go back to Dr. Evans's comment about the Black family and having this, not just as a precursor for next year's meeting, but also as part of talking about the Black family, because a lot of care is given within the family in terms of who, people, providing care, people historically, has come, with families. And the other thing that when we talk about healthcare is that one of the things that we are trying to do is build strong Black families. And families, no matter how you define the term, there are all sorts of families now. And so I think that's important. The other thing that I think that this panel has shown me at least is that there is so much more work and so much more research that needs to be done. And that, I hope that this panel has sparked an interest in some of the people who are taking part of this program in terms of what ways they can contribute, not just to the scholarship, but improving the life and health of Black people. Because as I once said on a panel many, many years ago, where it was an African-American studies panel at the University of Wisconsin, and they did not have a panel on health. But since I was a moderator, I took the chair's prerogative, the moderator's prerogative, to talk about healthcare. And I said, then all the others doesn't matter if you're sick, dying, or dead. And so that we have to think about that, in terms of the importance and the essentialness of healthcare and health.
Thank you, Dr. Gamble, University Professor of Medical Humanities and Professor of American Studies at George Washington University. Dr. Williams?
Yeah, I don't have much more to add other than to say it was truly an honor to be on this panel. I learned a lot from my colleagues here. And I think for me, take-home messages are, we've come a long way, but we've got a long way to go. This is no time for giving up. I love the emphasis of this panel because in many different ways, we also talked about, it's not just about survival, it's about thriving. And we need to make those investments in our relationships, in our community, that we will ensure thriving. Just this morning on CBS News, there was a special segment on the fact that since the death of George Floyd, 5,000 African Americans have moved to Ghana, West Africa, moved permanently, not going to visit, moved permanently. And the representative from Ghana was saying that right after George Floyd's death, they were getting 300 calls a day from African Americans in the US asking about the feasibility of moving to Ghana. Well, some of us are not moving, as wonderful as it is to visit Ghana, and we need to think of what we can do to continue to help our people, especially our young people, move from survival to thriving.
And Dr. Williams, I do have one quick follow-up question for you. The person asked it very early on. Lorna, just wanted to hear from you quickly about how would you encourage our people to seek mental health counseling? That was a question directly to you.
Well, I think we have to break down the stigma of mental health. Research that I and other researchers, when I was at University of Michigan, have done shows that African Americans are less likely to seek mental health problems, mental health counseling when they have mental health problems. By the way, that's not just African Americans. In America, there's a stigma of mental health, and more mental health care is provided by primary care providers than is provided by psychiatrists or psychologists or other clinical relationships. So I think we do need to break down the stigma and let people know if you have a heart problem, you want to go to the best cardiologist you can find. You have cancer, you want to get the best cancer specialist. Mental health problems are part of life, and that we do need to seek help. And so we need to work together to destigmatize it, and that means all of us. Churches need to play a role. I know I went to speak for something in Texas where there was an initiative for the African American church to sensitize the clergy about mental health problems and have them play a more active role. We need to think of more programs like that are community based, but that really help people understand how normative mental health problems are, how much for a very religious community, how much you see depression in the prophet Elijah in the Bible and so forth, and that these are normal things even for great heroes of faith, and that we need to seek help, and their help is available.
Thank you, Dr. Williams, Professor of Public Health and the Chair of the Department of Social and Behavioral Sciences, T.H. Chan School of Public Health, Harvard University, and last but definitely not least, Dr. John Bell, Thaddeus John Bell, sir.
Well, this is my my opportunity to encourage patients to get a good primary care physician. A primary care physician, family doctors are trained to deal with a lot of medical issues all at the same time. And one of the things that I think oftentimes goes unnoticed, it is unlikely that if you have a heart condition, you're probably going to have diabetes, you're probably going to have, you may have cancer, you may have hypertension. If you have a good primary care doctor who's trained to deal with all of those things at the same time to make sure that you get good care. So I would encourage folk to get a good primary care doctor, get and seek someone that you can trust and someone that cares about you. And don't be afraid to move to another doctor if the doctor that you are seeing you can't trust and you don't feel cares about you, because that's very, very important. Thank you.
Thank you so much, Dr. Bell, founder and CEO, Closing the Gap in Healthcare Incorporated. Please continue to check in with ASALH as we move forward with our conference for the month. I'm Dr. Kay Wise Whitehead, the National Secretary for ASALH, and we thank you for joining us this afternoon. Thank you.